Hello, everybody, and welcome. Welcome to When Your Data Wants to Talk, How Can You Hear It? Just a quick introduction. My name is Mark Clark. I'm Vice President of Strategic Development at Healthgrades. We are a database and marketing company that works with hundreds of hospitals across the country to help them understand the rich information that they have at their fingertips or should have at their fingertips to understand better their current customers, their future customers, do market development and analysis, and then ultimately take that analysis and make it actionable through strategic marketing programs to drive growth, retention, and volume within their organization. I'll be talking about and how the role that hard data plays in your lives, in my life every day, and we'll talk a little bit about agenda in a second. I want to have Andy go ahead and introduce herself before we get really into it.
Thank you, Mark. I'm Andy Simon, and it's truly a pleasure to be here with Mark to talk about how does your data speak to you. I'm a corporate anthropologist and president of Simon Associates Management Consultants, and our organization helps companies see, feel, and think in new ways about that very data. And as an anthropologist, we're very concerned about the meaning of the data. And since in Anthropology 101 we were taught data do not exist, the question is, how do we take this abundance of data and really understand its meaning? So today we're going to team up around this question. What's the data saying? How can you hear it? And what does it really mean as you are addressing these issues in your organizations? So to do that, I would like all of you to write down the reason that you came today to this session. And I'd like to then ask a couple of you to tell us so that we have a better understanding of it. And then Mark will do that. And then I'm going to turn this back to Mark and let him begin our discussion, because I think you're going to see the intersection of big data and small data in such a way as you can get better insights into the problems you're trying to solve and how we can help you see, feel, and think in new ways. Mark?
Thanks, Andy. I'll get into a full agenda in just a second, just to set up the discussion here. The theme for the conference that you're going to be embarking on over the next 3 or 4 days, Bridging Worlds. And so what we wanted to do is kind of give that sort of baseline of introducing that concept again and show how this information that we're going to go through today really fits within the concept that Shishman has come up with for the change agents that are going to be taking place over the next 10 years. So being nimble as change happens, generating data-driven insight, the idea of integrating data and co-creating and inventing new things from where nothing existed before, erasing the boundaries of what you think of what health business on the healthcare side is today, and then to Andy's expertise, telling stories and creating experiences. Those are all the different change agents that Shishman has pointed to that are transforming healthcare. And we think what we're going to be talking about today really is the intersecting generating data-driven insight on the top and telling stories and creating experiences on the bottom, or sort of the peanut butter and jelly, if you will, of those two ideas, bringing them together to really deriving new value where no value existed. And hopefully we'll talk through some strategies, some examples today on how you might be able to do that at your organization. So by way of agenda, just to get you level set, I'm going to start off in talking about hard data. Our expertise is really understanding the how and the what actually is happening right now. What can you learn from your data as far as what's going on in your organization that you may or may not know. We're going to go through some quick concepts, some samples of some information that you should be able to get to. I'm going to go through a real-world example, then turn it over to Andy, and she's going to sort of talk to her philosophies and some of the work the great work that she does within soft data, is understanding, providing subtext to the hard data. She's going to sort of pick up that same example and sort of take it to the next step, expertise's perspective. I'm going to come back and talk about a second example. We really want to make this real for you and not just give you theory, but give you theory and show you how it's applied in the real world. So we'll talk through a second example on geriatrics. Andy will then lend her expertise to that. Hopefully we'll summarize then at the end sort of the concepts and learnings that we've talked about so far. Take a quick break, and then we'll go into an interactive workshop where we'll sort of apply some of the methodologies that we'll talk through just now. So that being said, let's kick it off. So hard data. What is hard data in big data? Hard data in big data you might think of as spreadsheets. So zeros and ones on a sheet, charts and graphs, the things that, quite frankly, you might think are pretty dry and don't really pop off a page. Well, back to the theme of telling stories and providing insight, I want to start off the X's and O's conversation with a story. And that story is from a college campus in Florida that was designed by Frank Lloyd Wright, who is actually from Madison, Wisconsin, where I work. The campus of our organization is based in Madison, Wisconsin. So Frank Lloyd Wright designed a number of college campuses, but in this one in particular, Florida Southern, designed the college campus, presented his sketches to the college chancellor, the president, and showed him exactly how it all was going to look. College president, of course, was very impressed, but then took a beat in a second and looked more closely and said, "This is great, this is beautiful, but I don't see that there's any sidewalks in this campus. There's just a bunch of buildings. Where are the sidewalks?" Frank Lloyd Wright replied, "Well, there's no sidewalks because the students haven't yet chosen where they should be." So the point of that story being he was more interested in maximizing the usability of the sidewalks than building paths that no one would take. So the whole concept of letting the customer decide what pathways they want to take from point A to point B within your organization, rather than you dictating what directions they should go. This is really kind of the underlying theme to the approach that we like to take when we're trying to understand our customers a little better. What is that journey that your customers are taking today? How can you, and it's not about pushing them where you want them to go, it's about understanding where they're going today, so that you can help them along that journey in a very efficient, consultative way. So we're all about understanding the pathway, understanding the customer. So how do we do that in practice? A number of different ways. I always like to come back to starting with what is the objective? What are the things that you're trying to accomplish? In that example, it might be like we want to accomplish helping someone get from their dorm over to the chemistry lab in the most efficient way. But when we're in healthcare, we typically don't think about that pathway. What we really think about is the result, the episodic event. I got that person to the chemistry lab. In your terms, it might be something like growing share, it might be increasing volume or decreasing readmissions, whatever your particular goals are for your organization. I'm sure there are many different goals, but they're typically measured in point-in-time events. Did this happen? Did this not happen? But what we understand is that marketing is not necessarily only about did this happen or did this not happen. For example, hip surgery, did this happen or not happen? When we're in a marketing or business development perspective, yes, that's the measurement, but the real impact of what you do every day as business development or marketers is to change behavior. So the behavior that you're really trying to change is not just to have hip surgery, but to choose us for hip surgery, or to choose our doctors for whatever the most appropriate care is for you at this right time. So it's taking an existing behavior and modifying it to your financial benefit. So it's not about the end point of the journey, it's about the beginning of the journey and helping navigate along the path. And the things that you know about your customers, what do the things that you know about your customers, how does that impact how and in what manner in which you're going to change that behavior? So knowing who they are and what's happened before that episodic event plays a real significant role in how you talk to them, what you say, how you try to change that behavior. In the simplest forms, so things like hip surgery doesn't happen in a vacuum. Hip surgery happens after having seen someone else before that. People don't pick up the phone and say, hey, I'd like hip surgery tomorrow. There's usually a history there. So would it change how you impact behavior from a marketing perspective if you knew that this was a brand new patient? They'd never been to your facility before, or they have been to your facility before. Would it change the way you approach your messaging if you knew that they're a new patient, and their family member has already been a patient, or they're a new patient but nobody else in their household has ever been in before? Or conversely, if they're a former patient, does it matter to you or change how you might talk to this person or interact in that relationship if they were already an orthopedics patient, they've been talking to your specialist for a long time, and now you just want them to essentially keep having the hip surgery with you? Or if they're a former patient of other services, and it goes on and on and on and on and on. So the whole idea is healthcare is very complex, and the relationships that you're dealing with every day that happen before that behavior that you want to change, those relationships are very complex, and you need to understand that and how people think about that and feel about that as you're trying to change that behavior. So there's a lot of different preconceived notions that people are coming into that you need to be aware of when you're trying to develop marketing strategies. We'll take a different example. So that was an example of just on the highest level, the idea of looking backwards in time to just understand who you're talking to when you're trying to impact behavior. Hip surgery is an example. So let's take a different example. A very specific example might be we got a business problem where there's a competitor hospital that's impacting our cardiovascular volume. So the business problem is our volume is down, and here's the reason why. The objective of the research and the marketing is going to be, I want to pull from the northern market area to grow cath lab and interventional procedures. So the northern market might be where this competitor hospital is. Very specific goal, and it's a specific behavior change that you want to impact. So taking the same methodology, how do we understand how people are getting to that interventional procedures today? What's happening before that, which is the behavior that you can measure and look at in your data right now, to try to understand how people are getting, what paths are they currently taking to get to you, and is there any opportunity on that prior path to impact behavior, to put your message and to guide that customer along the journey the way you would like them to be. So certainly there's a few different approaches that we take when we're looking at this type of sort of quantitative research. So we want to first just do the descriptive, so the who and the what. So who's using this particular service and what are they using us for? So simple analyses like how far are they driving, so drive time analysis. Here's the event, how far are people driving for this particular procedure, what do people who have this procedure look like from a demographic perspective, are they older, they're younger, what's their ethnicity. So just descriptive information to get a better sense of who this person is that whose behavior you're trying to change. Then we like to take one step back and say, let's just not look at what type of people are using this particular service, but let's go horizontally a little bit and see what other types of services are these same people. Again, back to the hip example, this isn't happening in a vacuum. Healthcare is complex. So let's see what other types of services that the people who are using this service use. So how can we be your partner in building that relationship for other services? So you can look at what other hospitals or clinics or points of access within your system that people are accessing. Coming into the ER, some are going to inpatient, a lot of outpatient volume. You can see from a service line perspective what other service lines these patients are actually using, what the payer types are, giving you a more horizontal view of these patients and the relationships you currently have. How does that impact how you're going to talk to them, how you're going to guide them through this pathway? The last part about a good quantitative research, so one is just simple descriptive information. Number two is let's go a little more horizontal to understand what else is going on in these patients' lives. But then the real insight comes from being a little more curious. So let's asking a question, getting an answer, and then becoming curious about an answer and drilling down a little bit. So for example, in this particular analysis, we see there's a lot of outpatient visits that patients who have this particular procedure are having prior to coming in. So that got us a little curious, and we wanted to dig a little more deeply there. So what we did is look at all people who had an interventional cath procedure in a given time period, and then measured retroactively backwards and say, show me all the outpatient visits that those people are having prior to that event and group it by time. So I want to see how frequently and how often and how recently people are coming in for that particular procedure. What we found was there was a curious spike that led to an insight. And so people who are having interventional procedures, this is the sort of the chart, the descending order of when the most recent time those people were in the facility or in the inpatient or outpatient facility before that event. And you'll see between 30 and 90 days, there's this sort of spike in outpatient activity of people who are coming in to their doctor or a specialist before they have this interventional procedure. So what does that mean to us from a relationship standpoint? Is there's a lot of activity coming up before, so there's opportunity prior to an event while the people are in the care setting or just after the care setting to push out educational information to specifically educate them on specific actions that they can take to either head off a heart attack or things to be looking for in case of a heart attack or interventional procedure. So having the data help point you to specific opportunities. I'd like to just ask questions before we go into this journey. Does anyone in the room thought about looking at research in this way. So trying to understand not only who people are using services, but what else is going in their lives. Is there anyone else in the room that are thinking about it in this way? And ask that question.
Perfect.
So great. I'm glad a few of you have been thinking about it. We like to help our customers think about it even in a more structured way. So we just talked about one example, but we like to think, and some of the data I think we just showed, that healthcare really is a journey. It's not an episodic point in time thing. And I've got a few examples here to really call out why it's really important to understand that. At any given time right now, you can take a snapshot of your market and understand exactly where people are on this journey. There are people who are at risk for something like heart disease but don't know it yet. There are people who are feeling symptoms, so they're maybe doing some research. There are people who have had some diagnoses and are trying to research different options and services. And where they are on that journey, which you can quantify through your data, completely impacts how you're going to interact with them. For example, the person on the far right doesn't even know that they have heart disease, but they're at risk. So they're sitting on the couch eating chips. So we know that they're pre-diabetic. They occasionally visit their PCP, but they don't know that there's anything really wrong or haven't yet acted on that. So that person isn't open to talking about your great arrhythmia lab or how wonderful your heart attack services are. They're not thinking about it. Their aperture is not open. What they need to know is that heart disease often goes undetected, some education. You want to build awareness of that risk, something like a health risk assessment to try to get them to self-identify and understand that they are at risk. There's a lot of them, so only use broad, high-reach channels. Contrast that with somebody on the right who has already been diagnosed with arrhythmia. Maybe they're being medically managed, haven't had a catastrophic heart attack, but they have maybe a medical cardiologist. So they're already along that journey. They don't need a health risk assessment or a heart risk assessment. They know they've been diagnosed. So the message you talk to this person about might be very different. So they might be researching arrhythmia centers or looking for the best cardiologist in Madison. So maybe a targeted digital content strategy so that you're out there with specific educational information as they're searching for very specific information. So where they are on the journey completely impacts on what messaging, what information they need, so that your organization's goal is then to put that information out so that they can find it when they need it, and you're the provider. And increasingly, as everyone knows, that journey is starting online. So there's some very specific implications and strategies on what you do with this knowledge once you know it, and how you apply it, and where people are going to seek this information based on where they are on the journey. We know that 65% of people who go to the doctor have researched information before they go to the doctor. Something like 70% of all people who search for information on the internet on their cell phone also search for health information. So it's no secret that health information online is one of the fastest growing, is the largest source of traffic on the internet. So how do we leverage that? So how do we leverage it from a digital perspective? So one way to look at that is monitor and then leverage search engine behavior. So if you take that journey and you flip it on its head, from the top to bottom, you've got the symptoms, so the at-risk people are sort of above that. Then there's the symptom, diagnosis, procedure, and physician. So the journey can be also stated as a funnel. And if you're doing something like search engine marketing or SEO, where you're building content on your website, you can think about that patient journey and what you know about those patients as you're doing quantitative, and then apply that to digital. For example, search terms like cholesterol and heart flutter are indications that a person is on the symptomatic phase. They're very high in the funnel, and the information they're looking for is very high-level educational, down to a search term like heart center, beta blocker, ablation surgery. Those are very specific search terms where it indicates a person is down farther in the funnel. They've probably already seen someone, have been told something about their heart health, and so they're searching for very specific things. So again, using online behavior data to understand where someone is on that journey and what their educational needs are, and then mapping your strategy to that need. So for example, very top of the funnel, those very general search terms, that's a very large audience. And the information they're looking for is not very complex, just general information on what's cholesterol and what's heart flutter really mean, and the value that you're going to drive out of that particular person at that time is fairly low. So the strategic implication would be you need high reach channels because there's a lot of people. So high reach, high efficiency channels, something like search engine marketing, very broad messaging, can't go too deep, and very soft calls to action, so education and nurturing them along the way. Contrast that with somebody who's really down in the funnel, who you can identify either on your internal data or through their digital footprint. Something like somebody searching for a heart surgeon or a heart center. There's a lot fewer of them, and they're making a highly complex decision. So what does that mean? That means you can spend more per person because there's a lot fewer of them. Very specific messaging because they're looking for something very specific. So you're going to need to map your content to specific search terms. So do a research project to understand exactly what search terms are driving people to your hospital, and then develop specific content strategies to match those search terms. And your call to action would be very hard. So these people are ready to make an action right now to help make sense of their condition. So make an appointment, register today, things like that. And also your allocation of marketing spend can go from top to bottom on this chart. Some ideas of where you might look for some of the data. So we talked about the idea of the patient journey, quick information on some of the data points. So you can pull from your internal data, things like how people are navigating your system today, what clinics, what urgent cares, what hospitals, what physicians they're seeing. So you show your internal clinical data. You can look at your health education and wellness events, your e-newsletters, online assessments, a lot of your internal data. It's hiding a lot of different places, so make sure you're talking to all of your constituencies, your call center. You're talking to your nurse education team, talking to clinical, gathering all that information because it's all sources of rich information. Of course, some digital and Google and social, so you can look at search volume, search trends, and there's a lot more examples that we'll talk about today. Just want to throw some of this stuff out there. There's also a handout that once we get to the workshop portion, sort of a cheat sheet of a number of different places that you can find information. And again, we'll pull some of those examples as we continue to go. Once you understand that patient journey, you can then take that patient journey, you can take the descriptive information about who and what they are, and begin to plot out a cross-channel marketing plan that speaks directly to each individual based on where they are on this journey, and begin to attach channel mix, messaging, objectives, all from a very relevant perspective exactly to where that person is on the patient journey. We'll talk through before we get to the first case study is pattern analytics. So we talked about descriptive information, understanding the journey, understanding who they are from a demographic standpoint. Last thing we want to just touch on very quickly is pattern and predictive analytics. So pattern analytics is providing a vision on not what's happened, using what's happened in the past to predict what's going to happen in the future, so you can intervene if appropriate. So the simplest example here is mammography. So if you might do a profile of your existing patients and see that one woman is very rich, she's like clockwork, every year she's having her mammogram on a 12-month increment, and a different woman might be on like an 18-month schedule. So what you can do for pattern analytics is understand when that pattern deviates and then intervene when it does. So if that person who has been coming in for her mammogram every year, now all of a sudden it's been 18 months since her last mammogram, that's an indication that she's made some sort of decision to either use someone else or to stop getting a mammogram. You can use that information, that pattern analytics, to then trigger an interventional communication to try to get her back on schedule. This is the simplest example of that. Another example is a more complex example might be for using pattern analytics to optimize your growth objectives. So a growth objective might be to acquire new patients, but what we want to do is understand, are all new patients the same? What happens after we acquire that new patient? Are all new patients the same? Is the value we get out of each new patient the same, and what can we do to maximize that value? So we did a research project to look at, based on entry point, where's that first time they come into our system, that new acquisition patient, what is the retention rate of those new patients over 3 years? So what is the value we got? So we see here in this chart that if we acquire a new patient through a physician office visit, there's 77% of those patients stick with us for the next 3 years, versus an ER patient that we acquired, less than half of them stuck with us for over 3 years. So how does that impact your strategy? Not necessarily only from an acquisition standpoint, but then once you've acquired that new patient, an onboarding or a strategic nurturing program after that acquisition, this data can help you quantify the value of what that program might be. It might look like something like this. You can then take that pattern analytics, what you learned about who's going to stay with us, look at their potential value from a spend perspective, and then attach different strategies to that onboarding. So if there's a new patient acquired, you can stratify that new patient by, are they likely to be loyal, and are they high value? We really want to nurture that relationship. Are they they're medium likely to defect, and they have medium value? We want to grow that relationship. If the pattern analytics says there's somebody who's likely to defect and their value to your organization is fairly low, maybe we just kind of monitor that relationship and don't invest a lot in it. So using pattern and predictive analytics together. So the final key points to the introduction section here. So remember, patients are on a journey. It just doesn't all happen in a vacuum at once. They're frankly on multiple journeys at once. It's important to understand each stage and the interaction between those journeys. She might have hip pain and knee pain and need a flu shot and not have a primary care doctor. So what does that tell you about that relationship? The knowledge of existing behavior helps shape smarter strategies to influence future behavior. So knowing what's happening right now can help you understand what behavior you need to modify or don't need to, or need to reinforce as you're moving forward. Data can help you really understand who your customers are from a demographic standpoint. Some ideas of where your data might be hiding, a lot more to come, and predictive modeling can help you identify issues before they happen. So a real-world example that then Andy, before I hand it off to Andy to add context here. So urgent care centers, a lot of organizations are expanding or looking at expanding their urgent care footprint, understanding the new consumer trend, how consumerism is impacting choice, how it's moving more to a retail, I want my care now, that type of thing. From our example, we're taking a hypothetical customer who's looking to expand their urgent care footprint. And they wanted to see if it makes financial sense, if the trends that they're seeing are really holding true. Does it make financial sense? So if I expand into this area, is that going to bring more meaningful revenue into our organization? So in this environment, we start by asking questions. So when the business problem is, should we expand our urgent care, and is this something we should go into? Our first approach is, let's start brainstorming a bunch of questions that might help us gain insight to this problem. Does it make if we're going to attract new patients, who do we need to attract? Why are they using this urgent care in the first place? What options do they have already? What do they know about us already? Is it truly an entry point into the system? So I like to just, this is sort of practicum, I like to just brainstorm a whole bunch of things that might be curious and interesting for me to know. Then we whittle that list down into things that are going to be meaningful, and then we start running some numbers. So one example is pulling from digital. So user behavior. Is this really a consumerism trend that we can identify not only our internal data but externally? And certainly if you look at Google Trends, since 2004, search volume for urgent care has increased over 1,000% compared with just the more traditional pediatrician or physician terms. So clearly, at least online, if online user behavior is an indication, interest in this particular service is robust. So clue number one that you're on the right track. Let's just feed the system. Does this make financial sense? So we can look at your internal data of other urgent care centers and see, does it make financial sense? So in this case, there were over 6,000 urgent care patients that we then followed for a year to see if not only did that revenue stick, did we get additional revenue by acquiring patients through the urgent care? And yeah, 1,900 of them had subsequent visits. Specifically on the inpatient side, $2 million of contribution margin from those patients sourced through the urgent care. So from a financial standpoint, it certainly seems to make sense that acquiring people through urgent care is going to feed the system downstream in a meaningful way. Then we got curious about that. So that's the idea was, well, urgent care is an acquisition strategy, and yes, it feeds the system. Is it really all urgent cares are all new patients? And the reality is no. 51% of the visitors who came into the urgent care, those people that we were analyzing, half of them were already patients. They're already in the system for other needs. So it's certainly not exclusively an acquisition channel. It's also a retention channel and a convenience channel. So we'll look more into that. Of those that were brand new, only 28% of the people who were brand new had repeat visits. So actually less than ER average that we saw earlier. What does that mean from your retention standpoint? That's something that we really want to dig into. Certainly we can do the descriptive information, so what's the ages, what's the genders, what's the income, payer type, all this descriptive information to essentially develop a persona of who these people are. So essentially the data is saying, it's important when we turn over to Andy, the data is saying that these are sort of middle-aged women with kids, middle-income, working families. So that's what the data is telling us of the people who are using urgent care within this market. The data is telling them what are they using us for. They're using us for certainly for the standard urgent care style and sore throats, urgent care, heart aches and pains. But there's a very specific trend that we saw that people are using this not just for episodic care, but for routine care, routine health care, routine vaccinations, routine infant child checks. So they weren't using this not only because they couldn't get into their primary care, they're using this as primary care. What does that tell you about your strategy and how you need to then take that and feed that into your PCP strategy? And the last data point here is, if we're going to continue to do this, what's our customer satisfaction? So there's a site called Review Flow that you can get access to, that is an aggregator of online reviews. It can give you some sort of insight into customer service and what people are saying about you. In this case, this urgent care center is getting less than stellar ratings online, which really points to, yes, there's an opportunity, but to maximize this opportunity, we need to do something about this 2.2. We need to understand not just the what's going on, but as we hand it over to Andy, we want to understand why it's going on. We want to, her expertise was talk about a little bit more about what's going on in these individuals' heads that's making them choose or not choose an urgent care. How can we take this 2.2%, 2.2 average rating and make that a lot better? Turn it over to Andy.
Thanks so much, Mark. I think that many of you are probably thinking, wow, this is a ton of data. It's really a fabulous base from which we can begin to analyze our questions and situations. Mark has set us up with this question about urgent care, and we did this intentionally. We've been working for 6 months now with a client understanding their urgent care centers. And ironically, it became about because some of their own hospital staff began to complain about the quality of the care that they were receiving and the experiences in that hospital's 6 urgent care centers. So the tie-in is really quite important. If we're going to be thinking about how to use the urgent care system as a delivery channel, we're looking at, from Mark's data, what customers are doing, but why are they doing it and how do they feel about it? And what could this tell us? So let's talk about anthropology, anthropologists. So I'm a corporate anthropologist, and we work with companies that need or want to change. And I also spent 7 years in healthcare, and about a third of our company's clients are healthcare today. And they're all trying to adapt to both a changing consumer and a changing employer market. Anthropology is a study of our values, beliefs, and behaviors because humans live in cultures. And the point about this in the context for today is that we truly understand that big data, and that is a tremendous opportunity. But anthropologists understand that humans give meaning to everything we do, sometimes important meaning and sometimes incidental. We also are wonderfully driven by our habits. And if we don't better understand the human actions that that data is suggesting, and there's a story part to this as well, then we may be missing the real meaning of what's going on there and impart to it our own meaning. And I think that's the danger, because we see the data and we then impart to it a little like that college president did, where the sidewalks, well, there are none yet. Well, why aren't they? Well, we tend as humans to impart on others our own importance in what we think. So today I want to talk in the context of the hard data, soft data, is what did we see as we watched urgent care centers develop, and how could you use this methodology, because that's what we're going to aim for, so that you can set up an important mix between big data and small data and soft data so you can really understand what this means. So anthropology and anthropologists are usually thought about in terms of the field work that we do, because we have a tendency to go hang out. And most of the time people think of us working in small scale societies, Trobriand Islanders or Margaret Mead in Highlands of New Guinea. But over the last 50 years, people in anthropology have been working in complex societies and really better understanding how to apply that perspective, the theory, the method, and the tools to society all around us. We love to look at humans and what humans are doing because we're very creative critters, and often we don't even know what we're doing. If you ask people, they can't tell you, they just go about their daily lives. The method is the observation of people doing those daily lives, truly trying to understand what they are doing and how it means something to them. Ethnography is, think of it as undercover boss. It's the best advertising. You hang out and you begin to watch what people are doing and begin to talk to them about their stories. And the act of recording that, of what you're observing, often with cameras and other things, are terrific ways of beginning to capture them. We use other methods, and not so much focus groups, but I put that in there. A lot of storytelling sessions, and I'll talk to you about one. One-to-one interviews are about stories in an interpersonal way, and we use a ton of innovation games and play, because when people move into play, they show sides of themselves that they don't necessarily do when they're serious. We like to frame the problem. And as Mark was framing the problem for urgent care, you could hear the need for us to get down beyond we want to grow our urgent care business, or we want to make sure it's very satisfying. We really want to frame it in a way that we can use the methodology to better understand it. And this particular client was very interesting to us because we've done a good deal of work. They said, go hang out, see what's really happening. How will we know what really is the dynamics going on here so that we can improve the quality of the experience? So you need to begin to appreciate it. The strategy is then, of course, who do we talk to? What do you need to do to understand? And what will you listen for? And what are the pieces of information you're looking to gather? Because, like the big data, you're going to have an abundance. And what you're looking for are the insights, not the data or the information, but what does this really say to you and speak to you about the connections? And often the dots are there in very different ways. I love to do video, and you may as well, because what the camera captures gives you a way of taking those insights back and sharing them. And then this is sort of like a range of things that we would do. Sometimes we just hang out and watch. The one on the right, videoing a actual procedure, can provide enormous insights. The bottom one on the right here is innovation games that we played with the city of San Jose, California, 4 years in a row to help them build a better budget. And if you want to see something fascinating, watch 100 people redo the budget for the city, and they come up with really meaningful insights. And the one on the left is probably what you've thought about, where we hang out, listen, and watch what's going on. You can apply all of these yourselves. And at the end of the day, if you're done today and don't go back and try them, you're missing out on the opportunities of how seeing, feeling, and then thinking about something can give you good insights. So let's go back to urgent care now that you're an amateur anthropologist and you're ready to apply it. When we started working on this, we went into the press to see what's going on. And I loved this is not that long ago, but it's a simple model. There are 9,000 urgent care centers, and the race is on to profit from the rise of urgent care. I'm sure you remember when they were docking the boxes and they didn't do very well, but something's going on now that's changing the whole dimension of this. It's a low margin, high volume proposition. At Physician One, most people are in and out in about 30 minutes, and I'll tell you what we learned when we hung out. And the national average charge is about 155 per patient, and doing 30 or 35 exams a day is real interesting because as we worked with our clients, they weren't doing quite that many. Why are consumers choosing? Now, we saw the data and we saw how many are going, but why? And so part of this is what people are beginning to tell us as we listen to them. They said convenience down the street from me. It was fascinating as we listened to them. They are not necessarily trading quality for convenience, but boy, if you're not convenient, you don't exist. And when they said, why do you go to this particular one? Oh, it's down the street from my home. Or how about that one? Well, I was driving by and I saw it. It's a very retail, high visibility. Every one of the ones that we worked with, and I guess the total number is almost 100 people that we observed and listened to, 24/7. One woman said to us, well, I look up and see what their hours are, and if it's the hours that I can get in, that's where I go. Now, you need to hear these because we didn't hear a lot because that's where they have good doctors, or that's a good place. It's about me and how do I make it easy and convenient for me. And the cost, the average charge to treat a bronchitis is $122 compared with $800 in the emergency room. Lots of people with middle ear infections when we were watching this. It's the same $100 versus $500. So this is a low cost, highly convenient solution that we really need to pay attention to. With that as a problem, with the data as sort of as a backdrop, could we do ethnographic research and see how lots of users of different urgent care centers could tell us stories? So we sat in waiting rooms. I'll show you the pictures. We shadowed nurses. We really loved shadowing nurses, taking vital information. You can learn a lot when they ask you, where's your pharmacy and do you have a primary care doctor? We shadowed the physicians and listened to their conversations. We had lots of one-on-one interviews and innovation games. So let me show you. This is one out in Minneapolis, but it could be any. And I use it because it's not one that we spent time in, but I love the clean retail new look. And this is one that we love as well. It's in Stamford, Connecticut, and they've turned pediatrics into an after-hour care solution. And they're only open from 5 to 10, but parents are bringing their kids there for well care and all sorts of other care. And we're working with pediatricians now to evaluate an aftercare program. They think it's defensive. For Firefly, it's their business. Now, this is a view into one of the urgent care centers that we were working on. I want you to take a look at the people and begin to think through the data. About 60% are women and 40% are guys. And take a look at what you're seeing here at the number of guys that are doing their iPhones, waiting for their care. This was another experience, and we were watching because this one and this one were in the same urgent care center, not a lot of volume, and they were just hanging, waiting to find out. Neither of them thought a wait was good. They were there alone. How fast can I get inside? Was the conversation. Then in one urgent care center, we had 8 people that we hung out with, and they all had coughs. What was interesting is that 65% of the people go there for coughs. But what we heard was this. My wife told me to get to the UCC. My PCP retired. I really don't need one anymore. I came home from a trip from Italy with her, and I've been coughing for a week, and she's irritated at me, so she sent me to the doctor. I didn't come for myself. She sent me. Second one, cough. My roommates got tired of my coughing, so I came over to see what you can do for me. The doctor was cute. He said, maybe I should give your roommates the medicine or you. And it was just enough to be sort of cute, but not too cute. The third was my son was coming, and my husband thought I should go and see if you can stop this cough. And the question was, well, do you smoke? Yes, I do. Have you stopped smoking? Yes, I tried, but no, I haven't. And the whole conversation began to move around the illness as well as the smoke sensation. Then there were a range of other reasons, earaches that didn't go away. The medication that the last doctor gave me was different than this. Now, in these urgent care centers, you never see the same doctor necessarily. They rotate them. The sprains and back pains and, oh no, I don't want to wait for the pain doctor or the orthopedist, fix me now, was a common and recurring theme. My PCP told me to come. He didn't have any office hours today. I think I have food poisoning. The PCP sends them into lots of urgent care centers when they don't have time. It's becoming a backup for the ED maybe, but really for the primary care doctors. But often they're not sending them to a specific one, which is something we're beginning to think about and work on. The cuts that need stitching, as you can imagine, no more ED, I'll go to the urgent care. And the workman's comp that needed more care is a big area. One of the doctors said everyone comes on Monday because they don't want to go to work. There's an interesting pattern. And then there was a grandpa who came in with his grandson and said, you do back to school physicals, don't you? I have my grandson here. His mother's working. I have to take him. You can help. Now, remember I said men, women. This was one place. I loved this because they were all guys. And then later, there were still guys, lots of guys. But I loved the chairs between the people. And as we continued to do the research, they said to us, well, we don't want to sit next to somebody who's sick. Why would we want to do that? The pregnant woman, prenatal care in an urgent care center. What's going on? So from what we observed, we saw that observers were looking at the experience. We had facility placement, interior flow, exam room experiences, time waiting, knowing what was happening, clarity of post-discharge care, and the roles of the doctors and the nurses. When we did the interviews, the referrals were recommended weren't yet done. The PCP was interesting because as you looked at the data, it looked like there could be referrals to the PCP, But as we spoke to them, they said, well, I know I should go back to my PCP, but I haven't made an appointment yet. It's really much easier going to the Urgy Center. I go there because it's convenient. I go there because my doctor sent me. I go there because it didn't look busy, which then led us into innovation games. And I'll do this very briefly just to give you a sense of another methodology. We use a lot of innovation games because we are trained facilitators in it and we just love it. You can see this is serious play for serious work. Games, the toughest part of understanding people's behavior and how to modify it, and often about innovation, is actually predicting what people will do, what they'll pay for, what they really need. When we play games, we tap into their needs through the magic of gameplay. We deconstructed the urgent care centers with a game that's reverse everything. Take everything you do today, don't do it tomorrow, and see what you could do. So in this case, we facilitated. I put this up because you can see the abundance of ideas when you're not going to do what you used to do. And once we had all of those ideas, we bundled them together in a game called Build a Better Product Box. And with great seriousness, they begin to build a better urgent care center. And then the guys were great. I can only tell you they were fabulous. What they basically told us, I want fast and easy, simple and easy cells, regardless of the condition, the sex or the age. They wanted a fast, easy way to get to see a doctor or nurse, to get the care, the stitches, the pain, the magic pill. What they worried about, I check out the parking lot to see if they're busy, and can't they have a simpler way to check me in? Are they open when I need them? And smiles and kindness really matter. Can't you really help me? Smile. And during my exam, there was a lot of examination aggravation. Can you stay in touch with me? Manage my pain? I'm under stress. Put the urgent into urgent care. And afterwards, is anyone concerned about me? What do I do if I don't know what to do? Were the instructions really clear? How can I explain your instructions to my wife? So we started talking about, can you dictate it into their iPhone? Can you put it up as text messaging? Can I explain to your wife what's going on? What are we missing here? So how do we pull the big data and the little data together? One tells us the patterns and the trends. The other captures the emotions, the meaning, and the experience. Every one of those people with a cough didn't come in because I have a cough. They came in for somebody else. So if you're going to begin to market, what's the story you're going to tell? And how are you going to urge them to come to your urgent care? That business of smiles, fast and easy, those two people sitting in an empty office kept saying, well, how come I'm not being seen? And the ones who were put into the exam room wanted to know, how come they disappeared? One fellow said to me, that's sort of a silly thing. They make it seem like they're going to come in fast. One guy actually walked out of the exam room into the waiting room because he was really uncomfortable being alone in there for so long. And then the last point here is the role of the medical home. This is a very big piece of how we're going to theoretically deliver better care for a population. Where does urgent care fit into the medical home? And some insurance companies are actually designating urgent care centers as people's primary care centers. Stuff is changing. Are you going to be intentional and use these themes to build your business? Or are you going to let the consumer design it for you like those sidewalks? So let me turn this back over to Mark to talk about a second example that we can shed some light on as well. And Mark, we may want to pause here and see if there are some questions.
Certainly.
Please, Mark, up to you.
Okay. Great information about getting in the minds of how people think. So we're going to just go through one more quick example, a geriatric center. So set the stage. So in this case, this is, for us it was hypothetical, Andy's research is real, about a geriatric center where or actually I should say a facility who was considering turning one of their locations into a dedicated geriatric center. Was in a highly older population and and we were considering whether they should just brand this as a geriatric center and what would need to happen to do that. What's the business implications? So following our methodology, we would begin asking a bunch of questions. So things like let's throw them up on the board. So things like, if we're going to have this geriatric center, okay, what kind of specialists would we need to staff it? What procedures might these potential patients need? So if we actually acquired these new patients at the geriatric center, what are they going to need long term? Does it make financial sense? What kind of conditions are they concerned about right now? So what kind of specific educational programs are we going to need to put into this center? Do they just have one doctor? Do we need multiple specialists here? So threw up a bunch of questions. We then, again, per our process, throw up a bunch of questions, identify which ones are meaningful, what are the implications if I know what these questions, if I know the answers to these questions, how am I going to act on it? Get some answers, do some follow-up, and then drill down to sort of what the true insights might be. So just some of the things that we pulled out of some of this research. So, and to give you an idea of how you might do it, what kind of specialists? So the easiest way to find out what kind of specialists we would need to staff at this particular center would be to look at your current patients. So look at current patients over 65 in this area, and what kind of conditions do they have right now. So you can look to your internal data. You can spit out a spreadsheet, and we'll show you by volume what is going on in these patients' lives today. So in this particular example, it's pretty clear of what they have right now that needs to be managed. You would need a cardiologist, endocrinologist, nephrologist, neurologist, and psychiatrist, actually, in this area to serve the needs of the patients as they exist today. So using data to find out what specialists you would need. From a business perspective, assuming that you're taking care of those particular diagnoses, what might they need from a revenue and procedure standpoint? So if we're going to use this as a funnel into our hospital system, what do we need to prepare for downstream? Same thing, look to the data. The data will tell you what types of procedures are going on in the market. Either if you're in a market that happens to have state-reported data, you can look at both your internal information to see what procedures that are coming from this age group, and then you can also look to your competitors and the entire market share information to look for what procedures you might be missing. So get a rank order list, simple rank order list of visits by margin to see what type of procedures that you need to ramp up for or prepare for if you begin funneling geriatric patients into this geriatric center. So from a business development standpoint, important. So what do they need right now from a clinical perspective? What might they need in the future from a revenue perspective? We also want to provide insight back to the sitting on the couch example. What are their concerns today? A lot of people have health concerns that don't manifest as specific conditions from a diagnosis standpoint. So certainly Andy's research will show you some of that. You can point to additional sources to understand this, things like your own website and digital engagement. So if you can run Google Analytics on your existing hospital website, you can call up what particular search terms people are using to get to your website today. What people are actually typing in will give you a clue into what they're thinking about and concerned about, and then you can build programs around that. So for example, this sample hospital, you can pull up their search terms and you can quickly see, all right, people are coming or are typing in search terms. I'm concerned about ED, the fitness center. They want to make sure there's a fitness center. They're having trouble sleeping, and do you have a walk-in clinic? So using the customer's actual words as typed into Google to identify what they're concerned about today, you can then build services around these words, not only just from a content perspective on your website to help your SEO, but also in a very real sense, make sure you've got ED services, you've got a fitness center, all the services that people are looking for at your geriatric center. We also wanted to understand from a physician perspective. We talked about what kind of specialists might need to be there, how many. We looked retroactively at these people over 65 and counted how many doctors they've seen over a certain period of time. As a matter of fact, in this case, the average senior patient saw almost 4 doctors, different doctors, in any given year. So one of them got cut off there because they only saw him for a second. So what we learned for this, or at least took away from this, is there's a lot of specialty care going on, a lot of specialists and beyond primary care. So coordination care is very important from a marketing perspective. Make sure that's front and center, and maybe we need to look at hiring a care coordinator to help these patients navigate or sort of understand which doctor sees you for what and help you get better coordinated care. And the last thing we looked at is the idea of outmigration. So if we're going to build this and market this geriatric center, certainly we want to serve the needs of our existing patient base, but we also want to look from a business perspective, how can we use this to build market share beyond just a simple care. So outmigration is a way to look for what are people using services for away from you. So you can draw a boundary around your facility and pull a report on from either state reported data or your internal data, and we can talk through some of that. What are people driving outside of the market away from you to have that if you had that service there, you might be able to recapture in your market? So in this case, there are more than 22,000 claims that were leaving the area, driving away from the hospital for care that you could be providing. So in this case, almost half of the care for nephrology, for example, people were leaving the market for. So large opportunity then to if you build up those programs and make sure they're staffed and marketed properly, to recapture that business if it's profitable. Quick market share win by profiling where people are going, how people are navigating the system. In this case, they're taking paths away from you versus coming back to you. So a quick insight into what we would think about from a research and business development standpoint on if we're going to build it, will they come? Now Andy can jump in and begin to talk about rich insight on what they really need and how they feel about geriatric centers in particular.
Hey, thanks, Mark. It's interesting because this was a real situation, and the question was, which seniors are we going to look at, and what do they really have already? Is there a gap? Is there something that we should be doing that could really pull more into our network, because they're a very important part of the community? And remember, demography is destiny. If you have a large older adult population, it isn't another, it's something very special. So what could seniors actually tell us was the question. One of the things we did was segment it into 3 lifestyle segments. The go-go, I'll talk to you about that in a minute, and the slow-go, and then the no-go. And for our conversation here, those that are in home or residential care and have a difficult time going, we didn't want to focus on for this research purpose. The 2 groups we did focus on, though, probably are important parts of your markets. And if you look at Mark's data, you could see that they have a complex array of healthcare needs, some patterns, and I always like the 3.9 because I remember my mother and father-in-law had 3.9 doctors, and they enjoyed going to them often. I'm not sure the doctors enjoyed having them come as often, but there was a very interesting community of doctors that they all went to. The go-go senior is extremely important. It's not by age, because when we did our research, it wasn't how old they were, is what kind of lifestyle they were living. Are they active and healthy, and they want to stay that way? The go-go seniors live independently in their own home or condo or apartment. They may have a spouse or significant other. They may probably do not have an aide, truly don't live with a child or have one nearby, and often in today's world don't have any family members helping them. The slow-go seniors are an emerging and very large population. Remember, the largest growth is population over 80. These don't necessarily have to be over 80, but they are folks who need a little hand. They live independently in their own home, their condo or apartment with a spouse or someone else, but they may live in an assisted living facility. They may have an aide or a family member who helps them. And as you imagine these in your own market space, they're not incapacitated, but they are slow going. And as we brought them together to begin to better understand how a healthcare system could better help them, we began to hear different stories. The healthy no-go seniors really, and I'll come back to this again, but I want to take you through it at the beginning so you can begin to hear the differences. They were really interested in engaging them with education and prevention programs because they knew that someday they may be slow-go seniors. The slow-go seniors were ready. They wanted us to be ready for them when issues arise. Remember, speed and ease with the specialized clinics around high blood pressure, fainting, memory loss, and falls. And their physicians love our added value services. And the no-go, as they continue to age, will continue to be their go-to solution with our expert specialist, our nurse navigator, ongoing education, and care. All sounded good. Sounded like a healthcare organization might tell you. That was what we were going to do. So we framed our research objectives. What were the basic needs and wants in medical and healthcare that the no-go and the slow-go and the go-go and the slow-go were really into? What were unmet? I like to focus on unmet needs. What are they telling us about their frustrations? Because that's often an area where you can add value in an innovative way. Areas of satisfaction and dissatisfaction. with current senior healthcare options. We somehow fit people into our model, but maybe it's time we reverse that and begin to think through how we could fit into theirs. And we think about access, and in medical homes, you know how important it is to maintain great access, delivery, providers, the right providers in the right facilities, in the right locations. It's a time to step back and look at this enormous population and think about how we can collaboratively develop something that fits better for their needs, not just ours. What was a perceived value and benefits of a facility that provided medical services and programs for seniors? Should we put a geriatrician in there? Was a geriatrician good or bad? The work we're doing with hospice is very interesting now, because going into hospice is not something anyone wants to do, but they're very glad it's there. Is a geriatrician something nobody wants to have? It's not as if it's a pediatrician. And how do you engage the audience and present this so they see this medical system as a place to go for their health needs, and tell their friends and family about it, because that's extremely important. So, telling the story, as you can see, the difference between Mark and I is that Mark shows you the data. I'm going to show you a process that you can use to begin to listen differently, so you can begin to see and feel this in new ways before you then think about the data. This is all about storytelling. Now, why storytelling? The way the brain works is it takes a bunch of facts and it creates a story about them, a visualization. And it's that story that helps us decide what to do or not. Once you have the story, you then sort the facts coming through that brain and you make them conform to the story that you have. So if this healthcare system was going to help these go-go and slow-go seniors adapt to their growing elderliness, then we had to understand the stories and how they fit them together now, so that we could understand how we could fit either into those stories or, with greater difficulty, change the stories to fit ours. Now, I want to say that again, because this is about their stories, and are we going to fit into them or change them to better ones or different ones? Stories make ideas stick. Stories help us persuade. Remember, if you don't tell your story, they will make one up. Nobody will say, oh, I really don't know. They'll create something. Humans are very clever and creative, and they'll create something that makes them important, not necessarily you. And it's extremely important to understand how you're saying it, not just what you're saying. So we brought them together, and we had three groups. And then first we had go-go's, and then we had slow-go's. These are some of the images that we provided for them. And the process was very important because we wanted them to take those images and craft stories. It's easier if you have a picture book than if you have just a long worded book. It's about the images that we wanted and the stories they could tell. One of the things, regardless of what stage they were in, was that their basic motivating needs were not to get to doctors. It was to stay active and healthy. It was the reverse. So now we're doctors. How do we help you stay active and healthy? They wanted to be important and to matter to others. Those words came out so often it was almost heartbreaking, because in many cases they had no family around them and they were searching for meaning in their lives. And how could we be part of that if we could keep them active and healthy? And they also wanted their needs anticipated over and over again in the stories. And I'll tell you some more, was, you know what's happening to me before I do. Can't you help me understand it? I often thought it was a mixed blessing because they really didn't want to know, and I wasn't sure they were going to hear it, but it was an important part of what was coming out. Not a lot about their needs for clinical solutions, for physicians, or for gaps in care. The stories didn't focus on doctors. They focused on staying active and healthy. There were lots of gaps in listening and sharing. Once they were aware that their ability to be as active as they once were was not going to happen, and they were going to decline, in some cases had, they still wanted to do whatever they could to live life as fully as possible. So if you can think of this as a personal mission they're on, the question is, how can we fit into that personal mission in a fashion that they would gravitate to? They needed different things. The go-go seniors wanted preventive services and programs. The slow-go seniors wanted management of their healthcare conditions. Two different sets of needs. Same needs, different definition and meaning attributed to each. So as you're thinking about those seniors, is it preventative that we're doing or management? The stories, this business of wanting to matter is not something that just happens. And you might actually go through that buyer's journey because it started a long time ago. And are you helping them matter when they are when they are not really seniors yet? The desire to be important to others. How do you make it feel when you only have 15 minutes to meet with them, doctor, to make them seem like they really matter to you? To live a life that matters to others was revealed in every one of the early discussions. They talked about the characteristics of a best in class business and organization, what they were looking for. Those organizations and individuals watched over them, initiated contact with them. This is not that hard to think about, but could you in such a way as to make them think you really care? And it isn't just as a case manager, but in a much more soft, personal way. Their plea: preserve our dignity. Show that you and your organization are tuned to our needs and those of other seniors. And it's just not me personally. Plan ahead. They're moving into this proverbial uncharted waters. They haven't been before. It's not a lot of practice. And they want providers who know what the future may hold for them and head off issues before they become problems. I'll say this, having lived with older adults, they say that they may not really take your learnings to heart. So part of it is, how do you make them really hear it, not just say they want to? The doctors know what's coming next. We don't. Help us anticipate it. How would they craft this? These participants wanted a place that focused on them, not when they're sick, but when they're healthy. Which needs were they focused on? What were the attributes to define the facility? How should we communicate the essence of that story in an ideal and differentiated way? So if they weren't going to just simply another doctor, what was going to make this come alive? So I want to show you how the images came together. The top one shows you how many chose that image. The theme was patient-centered. It's about me, patient and family and community. So you can see the images that came together. The research was really very exciting because through images, we had a different number count. Now, Mark has numbers and data. We had numbers and data. They were images. How do we put them together? Coordinated care. All providers working together was a theme, came out through all the images. Convenience. Large physical center, variety of services, one-stop shopping. Please make it simple and easy. In the urgent cares, make it simple and easy. Among seniors is make it simple and easy. Take the complexity out. Is there a theme here about making humans more comfortable with simple and easy? And then keeping active and healthy, prevention. Now, came down to C's: convenience, care coordination, compassionate person-centered care, and community. And most of all, please, they wanted time. When their healthcare providers don't give them the time, it makes them feel the provider is not interested. But there are others who could give that time that isn't necessarily the provider. But if the provider dismisses or minimizes their concerns as part of getting old, makes them feel that they are not important, and causes this dissatisfaction with their providers. So, as we look at the peanut butter and jelly that you've been listening to, I'm going to turn it back over to Mark, and we're going to begin to talk about how we can solve your problems using big and little data in a way that can really make that peanut butter and jelly work together. Mark.
Great, thanks, Andy. Yeah, so just a couple points of summary before we move into the workshop phase. So I hope you're hearing how we really are mixing the great rich hard data, what's actually going on, with the softer, why is it going on, and what can we really learn about people, not patients, people, to help make those experiences better. So high level summary and tips for using your hard data. Hard data really helps you understand the what is happening right now. Very descriptive information, describes how people are behaving, how they're navigating, what they're doing. It does uncover. You can use it to uncover nuances and differences within groups or stages. So not only what's going on from a macro standpoint, but from a micro standpoint, are there differences in how people are behaving today? It can help you understand the impact on your business. What if I do this and I change this behavior? What should I expect, or what do I hope to expect, specifically on your business? So when you're going into the data mining, and we'll talk a little more when we get into the workshop proper, So have a hypothesis. What do you think is the opportunity or the problem? What do you think is the problem? Let's do some research to either validate or disprove what you think is actually going on. Make sure that you're considering that journey. So not just a point in time, what's happening at the time, or what's that behavior you want to change, but let's look consider looking at what is happening before that that we need to modify to either head off or increase the behavior that you want to change. So really consider that journey and the difference. Be curious. Were you right? Or is there something more here? The something more here is important too. So look at your hard data, look for trends, look for specific insight, but then become curious about that specific insight to see if there's any differences in there that you can make from a differentiation standpoint. That's really where your value is going to be, not just what's happening, but what might be different that you can leverage from a differentiation standpoint. At the same time, or actually, I take that back. So when you're developing this research plan and these questions, try not to limit yourself to what you think you have. So when we get to our whiteboarding session, make sure you just ask the question and then go find where the data is. So think about what you want to know without being limited to where you are going to find that information, because there's information everywhere, and we'll help find you exactly where that's going to be.
So now, every one of your goals is probably about behavior change, and we know how difficult it is for people to change their behavior. Think about how many people have heart attacks and don't change anything in their lifestyles. But you probably need to better understand what's driving that behavior along that entire buyer's journey. Now, what are the meanings, the needs, the beliefs, the attitudes, the behaviors, the culture? Culture is how we thrive, but now you want us to modify it, much less change it, to better understand how to change that person's beliefs and actions. What will motivate them to change it? Observational research can help really give you a perspective of what this really means, because I'll tell you, as we do this in different parts of the country, the meaning is very different and the same behaviors have different implications. So it isn't as if we're homogenized and look at it as by age, and it's not like you can simply project or predict. So get out of the office and stop believing your own stories, at least for a moment. You have to step outside a little bit like an anthropologist and look at it with fresh eyes. Open your ears and your minds. Listen for the dots that people are going to tell you that you're going to say, I didn't expect that. That curiosity is extremely important. See with fresh eyes. I say that 10 times because the brain has to see it to believe it. We see the old reptilian part of the brain is seeing. And so the words can mean lots of things, but when you see it, you go, that's what it means. And you'll have an aha moment where your brain will go, tuk, 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 and it will change it. And please let those customers help you craft the right solutions that they aren't even aware of. And I always love Henry Ford's quote, if I had asked people how to improve their transportation, they would have told me to make their horses go faster. And I'm a horse person, the horses don't go any faster.